Hello guys, I'm Scott, one of the reporting radiographers here at IUH Bath. You may have seen my knee image interpretation talk. So Dan, one of the ED doctors, has asked me to give a presentation to you guys on adult ankle trauma. So I'm going to share my screen with you now. Hopefully you can see my PowerPoint. And this talk will hopefully complement nicely the talk that Mike Allen recently did on ankle trauma also. I'll be focusing more on a image critique, reporting radiographer's perspective. It's not really within my remit to discuss fracture management or types of fracture to you guys, and I think Mike did such a great job of that. There's absolutely no need to go there. I will mention it here and there, but mainly I'll be just discussing the image interpretation side of things, just to complement his talk. So what are we going to be discussing today? We will look at basic anatomy, normal variants and accessory ossicles, fractures and soft tissue injuries around the mortise joints, and osteochondral injuries to talus. We'll then finish off with some small fractures that are easy to spot and are worth knowing about when you know to look for them. So, without further ado, on to our radiograph review. So as you all know, this is a nice example of a mortise view. And this is our basic anatomy that, again, I expect you're all very comfortable with. Today, we're going to focus a little bit more on a few other areas, such as the talar processes and the ankle syndesmosis, or the intraosseous membrane, or the distal tibiofibular joint, call it what you will, but it's this little region here. Also, when you're reviewing a mortise radiograph, we want to be seeing lovely equidistant joint spaces between the talus and the lateral malleolus and the medial malleolus. All the way around in an inverted U, we want to be seeing a joint that is equal in size. Now to the lateral view, and again, here's the basic anatomy. I'm not really going to bother delving into that. Bear in mind the base of fifth metatarsal, obviously. That should be visible on the lateral view, and it's always a nice place to check for an unsuspected fracture. Today, we are going to discuss in some detail about the posterior tibial malleolus, as you can see at the back of the tibia there. We'll mention appearances of the anterior ankle joint, and we will discuss a few bits and pieces of the dorsum of the talus and in particular. On this view, you know you've got a really good quality lateral radiograph when you can see a lovely clear joint space across the top of the talar dome, and also we can see a lovely outline of the posterior tibial cortex, and we can trace that for any cortical steps or lucencies involving that cortex. Obviously, we don't want to see those. Before we get into all of that, we'll just discuss quickly some normal variants whilst I've still got your attention. So, at the bottom of the distal fibula, the lateral malleolus, it's very common to see an os subfibulare, which is an unfused secondary ossification center. It comes about because as a child, these patients would have had an additional bone ossification center, and it just hasn't fused to the rest of the malleolus, and so it's a separate bony island. How do you tell it apart from a fracture? Well, aside from the obvious, it won't have overlying soft tissue swelling on its own. If it is the side that the patient has injured, that's not necessarily going to help you. So what you're looking for is lovely, well-corticated, smooth margins. As you can see here, these are not sharp or jagged. They're really well-defined and traceable. It has a characteristic location. It's always immediately beneath the lateral malleolus, and sometimes, as with this example, it actually superimposes. Lastly, we've got no donor site, so there's nothing that that bony fragment belongs into, unlike an avulsion fracture where you can often see where it has exactly come from. It is just superimposing along the top of it. Similarly, at the medial malleolus, we have the os subtibiale. So this is a secondary ossification center, just like the os subtibiale, it's due to failure of fusion of a childhood ossification secondary center. It's got a characteristic sort of upside down triangle or teardrop shape. It's always at the distal tip of the medial malleolus. And again, it's got really lovely, smooth, well-corticated margins. Just like your os subfibulare, there's no obvious donor site that it slots into. It just sits over the top of it. Last but certainly not least, and the most commonly seen, is the os Trigonum. Again, it's a failure of fusion. It's from the posterior talus. It's quite common. I think I see them daily whilst I'm reporting, certainly several a week. The thing to remember with this one is it has a characteristic location always immediately behind the talus on your lateral radiograph. Its shape can vary, so sometimes it's round, sometimes it's a tiny little oval or ellipse kind of shape. Sometimes it's much chunkier, but what's always reassuring is that this feature always has, again, smooth, well-corticated, lovely, easily traceable margins. So here's one example. It's kind of like an oblong shape, that one, isn't it? And we have another example here. As you can see, they're both in pretty much exactly the same position behind the talus on your lateral view. Whilst it's different in shape, it's the location and the margins that give it away as an os Trigonum. So we're now just going to start discussing some soft tissue signs. Now, unlike an elbow, an ankle joint effusion is not an absolute red flag that there is an occult fracture until proven otherwise. It's not like a lipohemathrosis in a knee where there is an occult fracture until proven otherwise. But your ankle effusion is still helpful. Like all other joint effusions, it is a distension of the joint capsule that's been caused by hemorrhage in the context of trauma. On your lateral view, we will see it as an area of grey puffiness in front of the ankle joint. The thing with the joint effusion is that it should just raise your index of suspicion that perhaps there is something amiss going on here. There may be an occult injury, not definitely, but there may be. If you see your joint effusion on the lateral view, you should be on high alert. You should really be having a second check. The patient has sustained a significant injury, which is why they do have an effusion. We want to make sure we don't miss a subtle fracture, such as your osteochondral defect, which we'll discuss in a bit more detail later on. Now, on the lateral view here, you can see demarcated by this yellow margin that I've drawn on, that area of grey puffiness at the front. That's your joint effusion on an ankle radiograph. That's where it occurs, and that's what you need to look for on this view. Now, the first kind of injury to the ankle mortise that I will discuss is the syndesmosis injury or rupture. It's easily missed. When we're presented with a nice ankle mortise view, what we're looking at, or what we're concentrating on, is the lateral and the medial malleoli, maybe the talus. We forget to check the syndesmosis, or we easily do, but we shouldn't when you know what to look for. So we want to make sure there's no widening between the distal tibia and fibula at that level. Approximately a centimetre above the joint line, we want to be finding the posterior tibial tubercle, which is this kind of longitudinal sclerotic line. And we want to measure the distance between that and the medial cortex of the distal fibula. This distance ought not to be between 4 or 6 millimetres. If it's wider, or if there is no overlap on your mortise view at that area, then you do need to be concerned as to the possibility of a syndesmosis injury. So, for example, the study on the right looks like a normal ankle radiograph. There's no fractures. The bony cortices are all intact. The joint space is fairly equidistant all the way around the talus, but if we just look in the region of the distal tibiofibular syndesmosis, that's widened and there is no overlap, so it's ruptured. Now, as Mike mentioned in his talk, the analogy of a polo mint or bony ring is a very important one to remember, that being that it's impossible to have a polo mint and only fracture through one area of it. The other side will always go. So these injuries tend to occur in pairs. If you're seeing a syndesmosis rupture, you do need to be mindful of possibility that you may have a mesonerve fracture higher up the fibula, and you need to be very carefully scrutinizing your medial malleolus to check that there's no contralateral injury. whilst we're on the subject of disruptions to the mortise, we will discuss now the importance of medial widening. So on the left here, we've got a lovely example of a normal mortise ankle radiograph with a lovely equidistant joint space all the way around. And now on this view, a different patient, there's substantial widening medially when you compare that to the lateral side by tracing those red outlines there. So this looks like quite a significant grade 3 sprain of the medial collateral ligaments. Sometimes you'll have a small avulsion fracture fragment here. But the important thing to remember is that as part of your bony ring, we've lost one part of it, which is the ligament holding your medial malleolus to the rest of the medial joint there. But where's the other injury? We can't see it at the moment, but we should be looking to exclude it. Again, it could be your major nerve fracture, especially as there's no other fracture to see at the lateral malleolus. Okay, so on a similar vein, our isolated medial malleolus fracture is our stock image of a nice normal ankle mortise. Now we've got a radiograph with a really subtle medial malleolus fracture. Tracing this medial cortex of the distal tibia downwards, we then see a lucency just at the origin of the medial malleolus that runs obliquely into the joint. That fracture on its own implies that there could be a problem elsewhere within the bony ring. We need to exclude that, okay? So as Mike was saying when he was describing his fracture configurations, do be suspicious as to the possibility of an additional injury when you're seeing fractures of this pattern. Medial malleolus fracture in isolation, you have to look for a further injury. Obviously, the reason being that two ankle fractures together is unstable, obviously. As an example, on this second view now, we've got a widening of the medial ankle joint and a distal fibular fracture, where we'd have to continue hunting as if we've only got that with no distal fibular fracture. So just be mindful about assessing your patients a bit further up the proximal fibula or mid-shaft with radiographs if you're concerned. So we're going to move on now to the posterior tibial malleolus. So on our nice lateral ankle view, we want to be seeing a lovely smooth posterior tibial cortex in the region of the posterior tibial malleolus here. What we've got to look out for are our undisplaced fractures in this region. They're easily missed. Most people go for the medial and lateral malleolus fractures. As soon as we don't see those, brain switches off a little bit. So on the lateral view, sometimes these fractures will show up as we see here, where we trace the posterior cortex down and our eyes are drawn into this oblique lucency running within the distal tibia. Note the anterior ankle joint effusion. And this is another example. So tracing our posterior tibial cortex all the way down, we're now at the tibial malleolus, and there is the most subtle of bony lucencies here, demarcated by the ring. And again, there is a subtle increased density anteriorly, which implies there's also a joint effusion here. Beware the undisplaced fracture. They're really subtle, especially as you often have superimposition of the distal fibula. And again, once we've seen one fracture, we have to be open to the possibility that there are more compromising the integrity of that bony ring. Again, it works both ways. If you're seeing an isolated distal fibular fracture all on its own, just be very careful and make sure you check this region of the posterior tibial malleolus also. Okay, guys, so we're getting through it quite nicely now. This is a patient who presented to the RUH 2 or 3 weeks ago. Very normal looking mortise view. Yes, there's buckets of soft tissue swelling laterally, but nothing else to see. So at this point, we're quite happy to dismiss this patient as having a nasty sprain. When you look at the lateral radiograph on the same patient, there's actually a sneaky distal fibular fracture hiding behind the tibia on this view. So tracing the posterior tibial cortex all the way down to the posterior tibial malleolus, there's no cortical steps there whatsoever. If you repeat the process with the posterior cortex of the distal fibula, if you get to this region, inside the ring, you can see that bony lucency extending through the distal fibula there, and it's frightening, isn't it? Because you cannot see that whatsoever on the frontal view. So something good to incorporate in your check of the lateral view is that posterior fibular cortex. Again, a fracture like this is unstable as soon as you see medial joint space widening or a fracture through the medial malleolus. Okay. So we finished our kind of disruptions to the mortise. We're going to move on to osteochondral fractures of the talus now. These are easily overlooked. There's not such a great knowledge of these injuries out there. Most people, as I was saying earlier, they tend to focus on, is there a lateral or a medial malleolus fracture? Is there a posterior tibial malleolus fracture? Once we don't see one, we're straight away beginning to dismiss this as a straightforward sprain again. Patients with osteochondral fractures of the talus have the same mechanism of injury normally as your classic ankle fractures. Inversion, fourth, things like that. On examination, they have pain and swelling. So with a normal radiograph thus far, we're just thinking sprain. The annoying thing about these injuries is that they do tend to be clinically significant when we miss them. After all, an osteochondral fracture is a loose fracture fragment sitting within a joint. Left alone, that's going to develop into osteoarthritis, pain, knocking, and leaves us wide open to litigation when the patient attends for a repeat study in a few years' time and we see a fracture that actually has been there all along. A very common basis for litigation, these injuries. How can we avoid missing them? How can we avoid predisposing a population of young patients getting early OA? We need to just assess the mortise radiograph differently. Okay, so once you've checked that there's no mortise fracture, we then need to go back to the mortise view. We need to be tracing the inverted view of our talus at the medial, lateral aspects and across the top. We're looking for any subtle bony lucencies or irregularities to the cortex. Happily for us, most of these osteochondral fractures occur at either the medial or the lateral corner. As the foot twists up during inversion, it tilts the talar dome into the undersurface of the tibia. That usually happens at the medial or the lateral corner. So here's an example of one. Lovely distal fibula, lovely medial malleolus. Tracing along the talar dome, we now see there's this irregularity at the medial corner. That's your osteochondral fracture, just a subtle lucency there. Again, on a different patient, tracing our talar dome from the medial aspect upwards across the top. There's another bony irregularity there at the superior lateral corner of the talar dome. They're really subtle injuries, but once you know to look for them, they're not so intimidating. Here's my last example. So oodles of soft tissue swelling over the lateral malleolus, but no fractures to see. At this point, we're just thinking a sprain. But if you check really carefully along your medial talar dome, across the top of it and down to the superolateral corner, there's a really subtle irregularity just in there. That's your osteochondral fracture. Okay, so we do need to pick these up, guys. Happily, injuries such as this often come with an ankle joint effusion on the lateral view. It's there to help you. If you see your ankle joint effusion on the lateral, do just have a double check of these regions of the talus on your AB or mortise view. So just a few more simple fractures to finish off with. Your anterior calcaneal process fracture, easily missed, very easily overlooked, simply because there's not a great awareness of this kind of injury. It's got a similar mechanism as our more common ankle injuries, so you will see them in your careers. It's caused by an avulsion of the bifurcated ligament as it attaches to the anterior superior aspect of the calcaneus. It only tends to be visible on two views, your lateral ankle and your oblique foot. So when you do request these studies, just get into the habit of checking these regions. So on your lateral view, we find the calcaneum. We're tracing along the cortex superiorly, underneath the subtalar joint, and then as we get right to the front of the calcaneum, you can just see that really sneaky, subtle longitudinal lucency superimposed with all the other bones, but that is your anterior calcaneal process avulsion fracture. Similarly, on the oblique foot, tracing the border of the calcaneum as it articulates with the cuboid, and we can just see now there's an irregularity here and a lucency denoted by the arrow running obliquely towards the subtalar joint. There's your avulsion fracture. Okay, last point, only because I see these missed and they are there for the taking. They're not hard to spot. These are the avulsion fractures of the dorsal cortex of your talus and navicular on your lateral view. So as with all loose ossific fragments, is it new or is it old? What tends to help you is the presence of soft tissue swelling and the shape of the fragment itself. Does it have a smooth border or is it irregular and jagged? So we'll get some images up for a nice example. Here's a lovely avulsion fracture of the navicular. That's an exceptionally large one, but this is just a nice example of the region you need to be scrutinizing on your lateral view. Look for the smaller fragments here. They're easy to spot. They've got nothing to hide behind. Now, my third bullet point of the above paragraph is your avulsion fracture from the medial or lateral talar process. These appear on the Mortise view, as you can see. Just a small sliver of bone arising from the lateral talar process, where I've just pointed to with an arrow for you there. Okay, so that concludes our talk. So we've discussed the basic anatomy. We've discussed a few additional areas to incorporate within our radiographic search. We've looked at some common normal variants, your accessory ossicles around the ankle, the most common fractures and their relationships with the bony ring, and the osteochondral injury to the talus, which is, I guess, something to really take home from this talk. And then we've wrapped up with a few of the more common avulsion fractures as well. So I'm going to stop sharing my screen now, guys. I hope you enjoyed that talk, and we'll be in touch with some more presentations soon. And stay safe out there. Thanks very much.